Maybe we'll take a little break halfway through this lecture. So we got about 49 slides to move through, and we're going to be talking specifically about the benefits and risks associated with using contrast media. Largely, we're going to be talking about iodinated contrast media or non-ionic contrast media. We're talking about how we need to be communicating about contrast media, contraindications, indications for its use, pregnancy, lactation, dialysis, documentation, adverse reactions, and as well as talking some about the myths around contrast media, because there's a lot of hokey stuff out there. The other thing I've realized, like in doing these YouTube lectures, just like how much I say so it's like an unavoidable thing. I sound like an idiot. So, do y'all remember from the book, it says to distinguish from adjacent tissues attenuation levels on a CT images, what's the amount of density difference we need to be able to? 10 HU. Good. This is why we're using oral and IV contrast, right? Of course, they didn't include rectal in there, but it's also why we're using rectal contrast. All right, so there's positive stuff like barium and iodine, right? Then the negative stuff like air and CO2. Basically, if you use room air, it's more more uncomfortable to the patient, but and the farts smell worse, right? If you use CO2, it is more comfortable to the patient, and for whatever reason, the farts smell better. So if you're interested in going into sales, there's a possible market right there for CO2 infusers for CT departments, if you like talking about. We're not going to talk about much today. Iodinated contrast agents are pretty much everywhere now. We like them because they're water soluble, easy to administer intravascularly, and safe like star, lots of fine print, right? So we have 120 pages of fine print from the ACR about just how quote-unquote safe they are. They are safe, except for that 1 out of sometimes 2 million people or 1 out of 200,000 people who have different kinds of reactions. But again, going back to that need to widen the difference in attenuation values on our CT images, that's why we're using contrast, right? Y'all remember me drawing up on the board all the different Hounsfield units and the little scale of Hounsfield units going from 0, what was 0? Yeah, distilled water. And if we're going in a positive range, we're talking about moving closer and closer to bones, so it's things that are wider and wider and wider on the image. And then if we're going towards a negative range, like a negative 1,000, we're talking about air, right? Sounds like Godzilla. It's like had the women and the children. Godzilla's in town. But the contrast media is just gonna infuse through the patient's vascular system, and it's going to help us see different kinds of enhancement patterns for different kinds of tissue. And so it largely has to do with its visibility, right? And it will also sometimes highlight certain abnormalities, right? It'll sometimes highlight things, for example, like cancers can do this weird, crazy thing where they create new blood vessels, right? Neovasculature. And so it's going to enhance. We're going to see an enhancement around that neovasculature. Let me think of another example. Pituitary tumor. Sometimes if we're doing a pituitary tumor CT or CT simulation, we might need to use contrast media to allow that pituitary tumor to enhance, so that we can differentiate it from other parts of the midbrain. Okay, osmolality. It's the number of particles in solution per unit as compared with blood. So HOCM, high osmolality contrast media, sometimes 7 times the osmolality of blood. 4 to 7 times the osmolality of blood. Low LOC, which is the predominant contrast media used now, at least in the United States, pretty much worldwide, is roughly twice the osmolality of blood. Isoosmolar agents are starting to hit the market now. I think Visipake from GE, I believe, is isoosmolar. It has the same osmolality as blood. So what is that talking about? One way to think about osmolality is if you had, I wish I tried to get two big, like 2-liter bottles, like clear 2-liter bottles. And let's say in one of these 2-liter bottles, I drop 1 drop of red food coloring, right? And you kind of watch it diffuse through that volume of fluid. It will not turn very red, right? It might completely absorb that drop of red food coloring, right? In the other one, though, I drop, let's say, 50 drops of red food coloring. It's going to be very, very, very red. So it's the same kind of thing when we're dealing with osmolality in the blood. Most medications, and this is a unique thing about contrast, most medications that we give, like morphine, right? She talks about morphine. It's given in a highly diluted form, incredibly diluted, right? It's a very small amount, and then they further dilute it with water. Then they administer it over a like 2-hour period of time, right? Contrast media, by comparison, I'm going to give like this much contrast media in less than a minute, right? So, and it has an increased osmolality already. It's the red bottle of water, right? The morphine is the clear bottle of water. So that's a factor. That's a factor in some of the stuff that we're seeing. Viscosity. The thickness or friction of a fluid as it flows. I would say this is probably one of the major safety concerns around contrast media. Probably circles this term viscosity. It's sticky stuff. Like if I was describing what contrast media is like to a patient, I would say it's like a Coca-Cola. If I opened up a can of Coca-Cola and poured it on this desk, the desk would be what? Sticky, right? If I opened up a bottle of contrast, have y'all ever seen contrast that gets dripped on the floor, dripped on the CT scanner? Same thing, sticky. It'll even crystallize and stuff like that, right? It can be very hard to get up, and it also can further compromise my images. If I get that contrast media inside the gantry, I want to get it off there as quickly as possible. Do y'all know why?
It can act as an artifact?
Yeah, totally. It could make an artifact there and influence my attenuation values, because now the scanner thinks, oh, there's something attenuating a whole lot over here, right? At just that gantry window. Is everyone tracking with me so far? So the Coca-Cola is a helpful thing too, because eventually when I'm getting informed consent with my patient, I'm going to have to explain to them, hey, you know what? What they're telling us right now in the research is that any amount of contrast media that I give you will probably cause renal dysfunction. It's going to cause your kidneys to go a little haywire, right? In fact, it can do something called contrast-induced nephrotoxicity, I believe. CIN. There's a real concern that it could cause permanent damage to your kidneys, right? Now, what are the odds of that? The patient's going to want to know. You're going to give me this stuff. How are you saying it's still safe? Opening that can of Coca-Cola and drinking it could also cause acute kidney problems. Right? It is going to cause some kidney dysfunction when you drink a Coke. You drink enough Cokes, you could have some kind of renal, like permanent renal nephrotoxicity. That's what we're talking about when we talk about diabetes and stuff, right? Someone had a few too many Coca-Colas sometimes. Leads to type 2 diabetes. So CIN is real. It is largely in patients who have a compromised renal clearance already. And so we want to be aware of that. We want to educate our patients on that, but we don't want to scare them about it. So I think the best way to compare it to is like a Coca-Cola. We love Coca-Colas, even though it causes some renal dysfunction and probably pancreatic cancer, right? I mean, Coca-Cola's probably got some serious lawsuits coming down the pipe in 5 years or so, I would guess. It can cause UTIs, stuff like that. I would recommend this stuff, right? This is live kombucha soda. It tastes like root beer. They have one that tastes like Coca-Cola. It's much more healthy. and it actually tastes okay. The guy invented it because his dad had type 2 diabetes, and he got it largely from drinking like the big gulp versions of Dr. Pepper every day, right? So there's now tasty alternatives, right? Same kind of process, same kind of thing, like in terms of educating our patients. Tasty option versus the Coca-Cola, right? Same things going on when we're marketed different kind of contrast media. The safety of the contrast media goes back to this viscosity question. Yes, you can give me one that's more like the osmolality of blood. Are we still dealing with the same level of viscosity? Because that's where we're learning the kidney problems come from. Does that make sense? Y'all tracking with me? Okay, great. Ionicity. So it can form ions in a solution. And we generally call contrast media non-ionic if we're trying to be fancy, right? That means it contains molecules that do not dissociate. In the past, and even there's still some LOCMs that can that are ionic, right? Most stuff is non-ionic. The terms non-ionic contrast media and low osmolality are not synonymous, is what I'm saying, right? Trying to remember, there was one that Mallinckrodt had, Hexabrix. Hexabrix was an LOCM that was still ionic. It's largely been discontinued. And just so you know, the big I tried to do some research on this, so I am speculating a little bit. But for an example of an HOCM that I think is still in use, I think gastrographin. I think, am I right about that? Okay, so you have it on my and Toya's good beliefs that gastrographin is an HOCM, and we continue to use it largely for oral contrast in some form of dilution, sometimes as a rectal contrast. Clearance. This is something that we use to describe kidney function, right? I don't normally hear techs talk about clearance, like does the patient have good clearance? They normally say, how's their kidneys, right? What they're asking is they're not asking, you don't need to answer, well, it's a bean-shaped organ that all vertebrates have two of them, and like they'll look at you like you're crazy. They're asking like, what's their clearance level? And so we have a number of ways that we're going to try to understand how metabolism is occurring within the kidneys, right? Largely, the half-life of contrast in patients, slide tells us 2 hours, right? That's if they've got good clearance. If they don't have good clearance, then that's when we can start to have some problems. Dose. We're giving them a lot, right? Like I said, the morphine would be like how many angels can dance on the head of a pin, right? That's the old heroin addicts question, right? This is how much contrast I'm giving them by contrast. By contrast. That was not, sorry, pun intended. So when we're considering the amount of iodine concentrate and the volume delivered, when we compare those kinds of things, we're talking about giving the person quite a bit of something that's sticky and weird that's going to cause the body to react, right? It's just kind of a no-brainer. If you give me this whole thing intravenously, even if it's just water, the whole blood system is going to need to respond to that increased volume of fluid in the blood, in the circulatory system, right? People will describe having a flush feeling. There's things that we still don't know about that acute response to contrast media. But I think it's largely just dependent on, I just injected this bottle of junk into your circulatory system, your blood vessels are going to dilate to accommodate that. Your kidneys are going to have to kick in to pick that stuff up. Your body's like, whoa, what the heck's going on? So, I know that our quizzes, I think online, have this question on them. Do y'all remember the calculation thing? So we've got a certain amount of iodine diluted, right, in 100 milliliters of an agent. And so any guesses what the answer is? How much iodine did this patient receive? 32 grams of iodine, right? That's a pretty normal range, like 32 to 53 or so grams of iodine. Just be aware it's again, fairly large amount for a dosage of anything, right? And this is the formula for how to arrive at that amount. This is an interesting point. Often we calculate a pediatric dose. If we're working at a peds hospital, and honestly, as a CT tech, I have not had a lot of pediatric experience, and that's because I've largely worked in cities that had good pediatric acute care hospitals, and so most of those patients went to those things. It's kind of a community education thing. You know, again, in Austin, I think the average level of education was a master's degree. No one brought their kids to, you know, my ER. They brought them to Dell Children's, right? In Memphis, I don't know. I haven't really looked at patient populations, but I imagine you will see more pediatric patients. Everyone knows Le Bonheur's a good hospital, but everyone knows, but there may not be the community health understanding that means I should take my kids there, you know, versus going to the ER down the road. So here's a very quick and easy way. Is this making sense? Do y'all see kids pretty regularly in the ER? Am I speculating? Yes, no, maybe?
You see them sometimes, but still there's a limit on what can be done for that child.
Right.
Yeah, they need to take it to a Bonheur.
Yeah, they have like the giraffe-shaped CT scanner or whatever, you know. And they use the CO2 so they don't fart and stink up the place, that kind of stuff. Good, thank you. But the formula for calculating pediatric dose, 2 milliliters per kilogram. Now, typically adult doses are uniform, and she asked the question, why? Why? Clearly there's a difference between, like CTing me and CTing some little fashion model, right, who's anorexic. There should be, but we're giving a uniform dose. I would get the same dose of contrast that she would, even though if I actually plugged it into the formula, she should be getting a lower dose. And she further points out this could be a potential cost savings for the hospital if they're drawing from, like sometimes we're able to hang like one big bottle of contrast and just draw off of that one big bottle. They've kind of done away with that, but you see people kind of float by with that. If you were drawing doses dependent on patient weight and kilogram, you might need to draw a reduced amount for certain folks. So just be aware, even though protocols generally call for a fixed amount, there's no rhyme or reason for that. There's no science behind that. It's just what people have gotten accustomed to, right? So there's need for more research there. There's need for people to question that. Okay, pregnancy. Generally, just because of the radiation concerns, we are not doing CT scans on pregnant folks. There are some exceptions, and one of the big ones would probably be pulmonary embolism. The risk for pulmonary embolism does increase with pregnancy, right? So that's kind of scary stuff when you think about it, that I may need to do a CT angiogram on someone, basically administer enough radiation to their chest to possibly cause some potential damage to the unborn child, right, if it were to receive that direct dose. Now, what's the main thing shielding, if I need to do a CT scan on a pregnant woman, what's the main thing shielding that child from the radiation? Mom. Yeah. It's almost like you got a little shield built in with mom. It's kind of weird stuff to think about, right? Still shield mom's belly, and that means front and back. Wrap her around with the lead aprons because she's getting the x-rays on every side. Limit the area of the scan field. So you may need to work with the RADs to develop a protocol where if I'm looking for PE, I'm just scanning the area where there could possibly be a PE. I don't need to include down to the adrenal glands, right? I don't necessarily need to include the apices of the lungs. I can just get those areas where those clots might be, right? There's other options, other ways to think about that. Some of this stuff is really worth questioning, especially if you're working in a hospital that has acute care. Why not take them to ultrasound, do a DVT ultrasound study before they even come to CT? If they've got a deep vein thrombosis, they're going to do the clot-breaking drugs anyways, no point in doing a CT scan. Does that make sense? ways to think about it. If you start to see more and more CT scans on pregnant folks, we definitely don't need to be scanning the abdomen pelvis unless it's an ectopic kind of question about ectopic pregnancy. But we may need to do CT scans of their chest, right? In terms of the contrast media, there's no proof that contrast media presents a risk to the fetus. However, there's not enough evidence to be certain that they pose no risk, right? So there, again, another gap in the research. We're continuing to try to figure that out. Could it potentially cross the placental thing? Yes. Could the baby be sitting in it? Yes. Does that cause long-term toxicity? We don't know. We can't say whether it does or whether it doesn't right now. We just don't have enough cases. Now, by contrast again, MRI contrast with a pregnant woman, big no-no. No one will ever do that, ever, right? MRI contrast is totally different kind of stuff. It's actually a heavy metal that's encased in something like an organic compound that if that organic compound dissociates, what we're left with is a heavy metal in someone's bloodstream. So again, if I give someone MRI contrast, they're pregnant, it crosses that placental barrier, and it's just circulating around this unborn child's circulatory system. That stuff's going to disassociate. Now we have a real toxic event going on, right? So just know, when I'm talking about CT contrast, there's not enough evidence to say that there's a risk. There's not enough evidence to say there's no risk. With MRI, there's enough evidence to say there's a risk. Questions about that? I respect y'all as techs, and so I want to make sure that I give y'all some of the resources to be informed and to guide informed patient care decisions. Because y'all, this will probably come up at some point in your career, and you're going to need to know, like, MRI, don't do it. Lactation. A very, very, very small percentage. She says it's like 0.1% could potentially, I think it was 1% or 0.1% could potentially wind up in the milk, and a reduced percentage would actually be absorbed by the nursing child, right? In the past, we weren't sure, so we would say pump and dump for 24 hours, which is always great as a guy to explain to a girl. But pretty much the guidance now is that it's believed to be safe for mothers of infants continuing breastfeeding after receiving iodine contrast, right? Again, there's a gap sometimes between all the radiologists go and have their powwow in Chicago every year. They don't invite any of the technologists to this thing. So the radiologists and the physicists talk about things all day long, and then no one remembers, oh yeah, we've got these techs who work for us who know how to operate the machinery, and we don't. Maybe we should tell them the stuff that we're learning. This is one of those big ones where we are continuing to tell, most techs continue to tell moms pump and dump, right? You don't need to. According to the ACR, the thing that the doctor said that no one reads, we don't need to. Okay, adverse effects. It's a very widely used medication. It's also one of the safest, and fatal reactions are extremely rare. So 0.001% is like one person in every 2 million people or something like that, I think. Would we see an actual fatality? So sometimes adverse reactions do occur, and it can be very difficult to, even impossible to predict. Once you have worked in CT or around contrast media enough, you start to get a nose for people who might, like, you actually can kind of detect this person is trying to give themselves a contrast reaction, you know? But the critical thing for us is to respond quickly and with brute force, crushing force, right? No, with professionalism and courtesy. But on that, now scratch courtesy out of that. You don't need to be polite. If someone's having a contrast reaction, forget about the yes ma'am, no ma'am, yes sir, no sir stuff. I need someone here and I need them now. Curse word, right? Because if I'm the person on the table and you did my CT scan and Benny, your CT educator, determined to have a contrast reaction on your butt, I want you cussing at the person who didn't show up, right? If you were that person on that table, you would want them screaming and yelling and saying, I need help. So anytime there's respiratory arrest, a need for resuscitation, forget about politeness. You know, politeness is not going to save their life. What's going to save their life is a fast response. That's one of the reasons I tend to talk fast when I'm talking about contrast is I've been in those situations and I know you have to kind of talk and think pretty quick. So the term contrast reaction, we generally call it a contrast reaction. And we use it a pretty broadly term. And it might be used to describe kind of the undesired effects, which include feeling a hot feeling, right? A metallic taste. I had one lady say it tasted like she was drinking tequila. I was like, either you're drinking better tequila or worse tequila than me. I don't know. Like, I don't think contrast tastes like that. Tastes like you have a penny in your mouth or something, like copper kind of taste. Always tell folks, especially women, you're going to feel like you wet your pants because for some reason when it hits down there, it feels like you just peed all over yourself. And I had a patient reach up and grab me like this. You have to tell people that they're going to feel like they wet their pants. And after that, I thought, yes, ma'am, you're right. I didn't realize that was such a trigger for you. The other instances of contrast reactions are more rare, and they may require some treatment. They can at times be life-threatening. This might as well. This is as good a place as any to talk about. I had this kind of skinny, emaciated guy. He was always wearing death metal T-shirts. You know, the patient, and he had some kind of Hodgkin's lymphoma, and he was on a trial. So he came back for CT scans every 3 months, and he would always barf all over the place. Right? What's going on with that? She mentions that it's a very small. Like she puts it so politely. She's like 0.02% of the people will experience emesis during CT scanning. And it's like, lady, just say that they're going to barf all over your machine because that's what they're going to do. Again, it's a very small percentage of people, but this guy would do it every single time. And if a person starts puking, there is no reason to scan their abdomen at that point because you're going to have way too much motion to have diagnostic images, and you've just exposed them to a buttload of radiation, right? Stop the scanner. You can continue the contrast injection. Stop the scanner. Don't initiate the scan. Go out there. Give them an emesis thing. Don't worry about cleaning it up. Save that for later. You know, the temptation is going to be like, you can sit there in that stuff, Buster. Don't say that. It's not helpful to him or you. Don't use the word Buster at all. But initiate the scan as soon as they're done puking their guts out, right? I don't know this. This is just off of my working experience. I think that is some kind of severe anxiety attack, right? Where the contrast media hits their system, they get that warm feeling, they don't like it, right? Who knows why that would initiate? That they have a personal reason why they do not like that, and it is so anxiety producing for them that it clenches their stomach up like this, and everything shoots up the tube, right? This is why we have emesis basins and emesis bags at hand. For that guy, it got to where I would just lay him down on the table, do my, I wouldn't even do a scout. I would just do the contrast injection with him with an emesis bag in his hand. He would puke into the emesis bag. Then I would do my scout and my scan, right? The contrast was still helpful because of the disease that we were trying to get, but it pretty much blew my timing. The important thing is if you've already done a scout, just ask the patient, please don't move. Like, don't be like that drummer from Led Zeppelin and aspirate or anything crazy like that, but like, if you can hold still, I'll get a better series of images, right? Any questions about people who puke all over the place? One of my favorite subjects. So I have a wealth of information on it. So broadly, we're going to categorize them as chemotoxic, and so that would be the CIN that we were talking about, the contrast-induced nephrotoxicity or what have you, and then idiosyncratic. Idiosyncratic is what we mean by allergy-like, right? Quote unquote. So sometimes it can be difficult to categorize, and I'm not going to be sitting there on the phone calling a code going, is this person having chemotoxic or idiosyncratic? No, just get back quick and bring the crash cart. So the idiosyncratic stuff, we don't really understand it. It's a mystery. And seldom, if rarely, is it actually an allergy. Why do we say that? The way allergies work, the definition of an allergy is if I give you something and you got some hives, the next time I give it to you, it's going to be worse. All of a sudden, you're not going to be able to breathe, right? Because your body's developing antibodies to whatever I gave you, and it's actually fighting you, right? That's a true allergy. What happens in our research in contrast media is there's kind of this yo-yo effect. Sometimes I give it to a person, they have a reaction. I might give it to them 5 months from now, and they're fine, right? Or they have a reduced reaction. The incidence of potential reactions does increase as with repeat exposure, but it doesn't necessarily increase in severity. So we call them idiosyncratic, allergy-like. If you want to be really fancy, you can say anaphylactoid reactions. Sometimes the doctors like to throw that word out there, and you're like, I know what you mean. You're talking about allergies. Don't ever say that. Even though it's not completely accurate, contrast allergy, people still say contrast allergy. I would not ask you to show up your text by saying, really it's not an allergy, but you can say that because you're kind of stupid. Don't say that. Just allow them to say contrast allergy, just allergy-like. Okay. Mild, moderate, severe. The mild one already is still kind of scary. And then, so I don't know who came up with these terms, but moderate is going to be not immediately life-threatening, but if you sit there and you're playing a game on your phone, it could become life-threatening pretty quickly. And then severe, we're going to say like immediately life-threatening, right? So the scale starts at pretty bad. So short duration, self-limiting, hives, right? Weird feelings, dizziness, nausea, things like that. Moderate, this is the stuff like shortness of breath, feel like your airway is closing off. You go into something like shock, right? So if I don't do something to stop that shock response, we're talking about like you not being too happy in 10-15 minutes. Severe is like very, 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 very rare. Again, I think I said 1 in 2 million people. I think that's what she writes about in the text. But this is like you give it to them and they're gone. It can happen, right? It can happen. But again, it's very rare. And generally those people have y'all ever heard the term circling the drain? They're already on their way out. There's enough other stuff going on that there's still a need for the CT scan. We understand the risks. It's kind of a life or death situation already. So, risk factors for this idiosyncratic reaction, previous contrast media reaction. Yes, it is still a risk factor. It increases the percentage by some amount. It's significant. Asthma. So if a person does have asthma, I am concerned about them having a contrast media. I have asthma. Do you have your inhaler? That's going to be the best way to quickly, make sure that we don't have any problems. Go ahead and take a few puffs on the inhaler before we even start with the CT scan. History of allergy to food, drugs, other substances. So if we're like the boy in the bubble, we got a big long laundry list of allergies. You're allergic to red dye number 5, tomatoes. You're allergic to hospitals. You can kind of, the risk of allergy of a reaction increases, right? I would say simultaneously the risk of someone, again, having some kind of anxiety response, and I don't mean to diminish the significance of anxiety. It's a real thing. It can trigger some very difficult things for the patient. So if you have someone who appears anxious, who is almost like priming themselves for a contrast reaction, be aware of that and do whatever you can to put them at ease. Now, there's like bad putting someone at ease and good putting someone at ease, right? This person does not want to be your best friend necessarily. You don't need to crawl onto the table with them and say, I get scared sometimes too, and read them a book, right? The best thing you can do is be professional in your conduct, answer any questions that they might have, be professional in your speech and your communication, express empathy. Hey, I know this is hard. I'm sorry this is going on. I'm going to do my best to take care of you. Like, it is my job to make sure that this CT scan is, we get the best quality pictures, so that we can figure out what's going on, and I'm on your team, right? I need you to be on my team right now, because that's the best way we can figure out what's going on and get you back to doing what you like to do, right? If I was a patient, that would put me at ease, right? So I guess the golden rule, treat others like you'd want to be treated. Interestingly enough, seafood allergy doesn't pose a particular risk. We continue to ask people about it. Are you allergic to shellfish? Again, it's one of those moments when the doctor sat down and realized, hey, there's no correlation. But hey, continue to ask them. We think it's cute. Continue to ask them about the shellfish stuff. It's cute. No correlation. This is cute. Totally different stuff. All right. Preventative measures. You can just do the exam without contrast. That sometimes can be recommended. At other times you can't. Use LOCM. That's good. Pre-treat with steroids. And she actually has a really helpful box in the text that tells us what that pre-treatment regimen looks like. Typically it's like prednisone 13 hours before, prednisone like 5 hours before, prednisone and Benadryl an hour before. Most places I've worked at is just kind of oral prednisone treatment and then Benadryl and prednisone. And those patients are the patients you love because they show up, and with the exception of Dustin, they're feeling pretty good. You don't like prednisone, right? I love prednisone. I wish I had some right now. Has anyone got any prednisone? I'm just teasing. No, it generally puts people, they just kind of are more sedate, right? I also love that she says that using diazepam Valium on patients can reduce the risk of seizure. It's like, just give them all Valium then. Give them all Valium. It would be wonderful. Like, there should just be Valium misters in the CT room, and no one would be puking or anything. We'd all be having fun.
You wouldn't have to tell them to be still. You wouldn't have to tell them to do
No, it's just, man, this is going to be so chill and relaxed. Just lay down. It's cool. Listen to the music. All right. Pre-treat with steroids. Documenting adverse reactions. You got to document. The amount and type of contrast used, signs and symptoms of the reactions, hives, redness, shortness of breath, complained of their throat was closing off, drop in blood pressure, interventions, medications used, and the time that they were given, right? How the patient responded after we gave them the epinephrine or whatever, the EpiPen. If you ever get a chance to, like, if they're ever breaking down the crash cart, run over there and say, hey, show me the EpiPen, I want to see what it looks like. And then grab it and stab them with it. No. Understand that's kind of how it works. You stab someone with it. I wish I knew more about how it worked, because, like, it would be a very helpful thing to know, but you don't need to run around stabbing people with it. It's just, that's how it works. So if you do that, you would already know more than me. I'm trying to teach you how to be smarter than me. Final outcome. Patient recovered after an hour. Monitor the patient for an hour. Blood pressures at this, and this time. 15-minute intervals. Return to normal. Walking and talking. Released on their own recognizance. Picked up by a family member. Whatever. This also needs to be entered into the EMR and flagged. Contrast media reaction. And input it into our EMR now. So they can track that. Chemotoxic reactions. So we just finished talking about idiosyncratic, now let's talk about the chemotoxic stuff. Contrast-induced nephropathy, which I just love the word nephropathy. Effects on thyroid function, pulmonary effects, I hate saying this word, pheochromocytoma, and certain central nervous system effects. She talks about the possibility of triggering seizures if a person has like a known tumor or something like that. And then delayed reactions. So there has been one case, I think, of a reaction. Someone had a contrast reaction, they think, as far out as a week after a CT scan. Very rare. Like the incident of that is like 1 in however many people there are on the planet. They were just a unique person. They really wanted to celebrate their uniqueness and their diversity by waiting a week to have a contrast reaction. Most people.
How does that even happen if your kidneys filter it out?
I don't know. I don't know. It's just there in the records, and it's like no one can. Like everyone hates the guy who reported it, and no one can figure out how it happened or anything. I really don't know. Most people, if they're going to have a reaction, they're going to have it within an hour. Almost everyone else, except for that one weird person. I'm sorry if you were that weird person. I don't hate you. I just question how that occurred. Most people, it's going to be within 2 minutes. A lot of people, it's going to be within like 30 seconds or something. And one thing that is going to trigger you, like your antenna should go up, the spider senses should start tinkling if a person sneezes. If they sneeze, chances are you need to get your butt into that room. That's typically the first thing that happens. They sneeze, or they say, I can't breathe. I had one person say, I can't talk. I did not question her on that philosophical point, but I did get my butt into the room and figure out what was going on, right? Yeah. Contrast media-induced nephropathy, CIN. So intravascular contrast media can affect kidney function. The current ACR recommendations acknowledge that it impairs cause renal dysfunction, right? If the kidneys are healthy, if they're clearing out stuff, then there shouldn't be a problem. But what happens is, if it's not, that stuff can sit in the kidneys, and it actually starts to form like little crystal sheaths around the glomerular filtration capsules inside the kidneys. So the little sticky stuff on the side of your machine where all the contrast stripped down, or the sticky spot of Coca-Cola on your counter, that's happening inside their kidneys now, right? That doesn't sound like fun to me, and it can eventually lead to like permanent kidney damage. Okay. Any guesses what's the number one thing that we can do to reduce this as technology?
Liquid it.
Yes, thank you. Hydrate, hydrate, hydrate. Today, we're giving you something that's actually going to affect the way your kidneys function. What I need you to do, Mr. Smith, is drink more water. Not beer. I've heard that joke 50 times. Water. Not wine. Water. Not Coca-Cola. Water. Coffee. No. Water. Water, water, water. Water before and water after. Hydrating them before and after reduces incidence of contrast media reactions, and also is going to greatly increase their clearance, reduce their risks for nephropathy. It's not going to change the color of your pee or anything like that if they ask you about that. You're not going to pee funny. It's not radioactive. Some people think, oh, I get to glow in the dark. Well, I had never heard that one. But no, you're not going to glow in the dark because it's not radioactive. Nothing that we did today was radioactive. So, yes. Renal function, and this is one of the things that we're really going to dwell on when we come back to contrast media in the summer. A lot of question marks on this slide. So the way that we express clearance for the kidneys is under a lot of there's a lot of questions. Let's just put it that way. ACR has made recommendations, but a lot of those recommendations have not trickled down to hospital policy, right? So we're still asking them some goofy questions, and we're still looking at some numbers that we may not necessarily need to be looking at. ACR is now saying largely we need to be looking at a glomerular filtration rate, right? The more healthy the kidneys are, the higher that GFR is going to be, right? The lower their creatinine will be. So in the past, a lot of times we were looking at a creatinine range of like 0.6 to like 1.2. It was a little institution dependent. She says 1.7. I've never thought that that was a healthy creatinine level. But it would depend some on the patient's age. If I've got an 82-year-old man, he's got a creatinine of 1.7, I'm probably not going to give him contrast media. If I've got a 27-year-old man, I'm going to tell him to stop eating so much steak and give him contrast media, right? And drink more water and less beer. So these lifestyle questions have a big influence on how your body's clearing creatinine. Creatinine is just a byproduct of using your muscles. Like right now, my body is producing a lot of creatinine by the intelligent use of my mouth muscles right now, and my kidneys are clearing that out. So this glomerular filtration rate is largely calculated based on the patient's age, gender, ethnicity, and creatinine. We take those variables, we plug them into a formula, and it's going to spit out a number. The higher the number is, the better, right? In the past, we would just look at creatinine and say, oh, your creatinine's okay. And they'd be like, what's a creatinine? And you have to explain to them that it's muscle stuff. So I think that the push is going to be towards GFR. The question marks for us are going to be, which is better? Which are techs more comfortable with? What are we seeing at a corporate level? Like, we're going to try to help guide some policy here at the hospital. Because there's still, the Baptist Corporation has not yet completely adopted the GFR, right? And so I would argue that we need to make a case for adopting the GFR. I'm going to encourage us to do a little bit of research in ourselves, in our work environments and stuff, and see what we can learn about that. Okay? That will be in the summer. Serum creatinine. This is kind of the old school way of doing things that's still around. And it's very inexpensive. They've got iStat machines that you can just, get a quick blood sample and know what their creatinine is. And from that, we can kind of figure out how their kidneys are clearing stuff. So, there's a few different terms that we should use. Renal failure is bad, right? It's going to result in all sorts of problems because the body is no longer going to be able to maintain homeostasis. And we're going to have the accumulation of nitrogenous waste. This can even lead to some forms of dementia, right? Renal failure is not good stuff. Renal insufficiency, so abnormal but sustaining essential body function. So renal failure, this is someone with a creatinine of 7, right? Serum creatinine of 7. They are in renal failure. Their kidneys are no longer working. They have a high level of, it's not actually the creatinine that's causing the nephrotoxic stuff, it's the BUN, it's the blood uric nitrogen stuff. It's all the nitrogen that's in their blood system. Renal insufficiency. Someone that's got like a creatinine of 1.7 to 2 or somewhere in there. Kidneys are doing their thing, kind of limping down the road a little bit, but they're still alive and they're ready for a fight. Nephropathy. This is just kind of a broad term denoting stuff that is affecting the kidneys. Can be used synonymously with renal impairment. Most of your patients are going to be like, renal failure, what are you talking about, Just be prepared to explain to them, hey sir, I probably need to be going on dialysis. No, you're not a doctor, don't tell them they need to go on dialysis. But renal failure means that your kidneys aren't,
Dead.
Yeah, your kidneys be dead. Your kidneys are not clearing nitrogen from your blood. And they'll be like, what's nitrogen? Well, yeah. Yeah. So CIN is an acute impairment of renal function, and it can occur after intravascular administration of contrast media. We are going to see a progressive rise in serum creatinine in this patient. Right? Again, those crystals are forming in the glomerulus of the kidney, and they ain't going away. Right? So less and less creatinine is being filtered out of the blood, and the nitrogen levels are rising. So, if we have a CIN risk factors, now look at this. Creatinine clearance less than 25 milliliters per minute. So they're not clearing creatinine. Unfortunately, she doesn't give us what the serum creatinine would be for that number. Recognize that's not a creatinine of 25, right? If you got a person with creatinine of 25, like they're a robot or something, like that's not even humanly possible. So I wish I had the actual number there, but she doesn't include it. So another risk factor, diabetes mellitus, however you want to say it. Diabetes. History of recent administration of iodinated contrast media is so if they had a CT scan 2 days ago, probably don't need to be giving them more CT contrast, right? So be tracking when was your last CT scan, did they use contrast, etc., especially if they've already got an elevated creatinine. History of congestive heart failure, CHF. So you can see all these things, even though we're talking about different systems and stuff, all of these things can kind of combine to influence things. Why would the heart be in there? Any guesses why the heart would be in there?
Because if you have heart failure, you're not pumping blood. If you're not pumping blood, your kidneys aren't flushing out stuff.
Yeah, that's a good point. Like in the textbook, she says something like 25% of arterial blood goes to the kidneys. That's like a lot of blood, right? So if my heart's in failure, is chug. It's the contrast is slowly going into the kidneys, and that creatinine is sitting in there making its little sugar crystals, right? Ways to prevent it. Identify the patients with a high risk. So diabetes mellitus is one of the big ones. Use LOCM or an isoosmolar contrast media like Visipake. I think most of the Baptist hospitals use Omnipaque. Ensure adequate patient hydration. That's like the technical way of saying drink water, damn it. Minimize the contrast media volume. So here again is an argument for doing a contrast dose based on the patient's weight. Because that's like 65-pound lady, I don't need to be giving, her, Jerry the King Lawler's dose of contrast media, but that's what we do. Do people still know who Jerry the King Lawler is? Is he still doing like fireworks stand advertisements? Tristan's like, no, it's so lame. I'm like beyond that. I've moved on to like WWF Raw. I know nothing about wrestling. I'm sorry. All right, so allow at least 2 days between contrast media and exams, and discontinue other nephrotoxic medications. Like I think she mentions beta blockers. I think another one was NSAIDs. She had a little list of medications. I really should know more about that. I'm sorry. So, can it result in CIN? Yes, it can. When patients are taking metformin. This is another question mark slide. The ACR, I'm looking at their current recommendations. And here's another place to question policy a little bit. Patients taking metformin are not at a higher risk than other patients for post-contrast acute injury. Iodinated contrast is a potential concern for furthering renal damage in patients with acute kidney injury and in patients with severe chronic kidney disease. There have been no reports of lactic acidosis following intravenous iodinated contrast media administration in patients properly selected for metformin administration. Their final recommendation as of August 2015 is the committee recommends that patients taking metformin be classified in 2 separate classifications, and they talk about their eGFR. Right? So clearly there's a need for more thought about this, right? In the past, we just kind of blanket statement ask people, hey, are you taking metformin? Okay, DC that for 48 hours, call your doctor, right? They're finding out some interesting stuff about metformin. In fact, I just found some research that metformin may be a longevity drug, may actually increase people's lifespan. So there's reasons why people are starting to question this stuff about metformin. Metformin's interesting right now. But in the past and in general, we tell people to DC it for 2 days, and assuming the kidney function is normal, go back on it. They'll need to talk to the ordering physician for metformin. There's no reason to DC metformin if you're giving them gadolinium. If you're working in MRI and you're giving them gadolinium contrast, metformin's not even a factor. Okay, dialysis. So if I do have a person who's in renal failure, typically they are going to be on dialysis. And so I can give them contrast media. You'll notice if they have dialysis with end-stage renal failure, right? We just need to do that kind of to coincide with their dialysis schedule, right? Ideally, what you're going to do, you can't call up the dialysis place and say like, hey, I need to change this guy's appointment, because they will laugh at you. But what you're going to try to do is schedule the CT scan immediately before the dialysis appointment, right? Questions about that? Nuke Med, have y'all had to do that kind of stuff? No? Okay. And just to point out, I know the Nuke Med folks are already aware of this. The kind of iodinated stuff that I'm talking about is very different from the kind of nuclear medicine iodine that they're using. They're using a radiopharmaceutical that's a radioisotope form of iodine, and they can use that both for diagnostic purposes and also for therapeutic purposes. So bow down and worship the ground that the Nuke Med people walk on, because they can cure people of thyroid cancer, right? But they're also kind of crazy to be working around radioisotopes all day long. I know nothing about radioisotopes. So, think that about that. So, if I'm going through the questionnaire, the patient says, hey, I'm in renal failure. Okay, I'm going to say, what's the first thing I'm going to ask them?
When's your next dialysis appointment?
When's your next dialysis appointment? This afternoon? Great. All right, let's go ahead and do the CT scan.
No, we'll wait.
Yeah, tomorrow? Okay, let's reschedule the CT scan. When's the dialysis appointment? We're going to try to do it before. If it's like butt crack of dawn dialysis appointment, which typically isn't because the dialysis people have banker's hours, what I'm going to do is I'm either going to do that CT scan as late as possible that night or as early as possible the next morning. Okay? Because otherwise that creatinine's just sitting there making its little crystals in their kidneys. So, no effect on patients with normal thyroid function. Give them iodine all day long. I do want to be aware of what the Nuke Med folks are up to, right? And they need to be a little aware of what I'm up to. Because if they're slated for an iodine injection to treat their thyroid, then they should not have had a CT scan within what? What is it? Y'all remember? 2 weeks. 2 weeks. You need to be looking at back at their chart. When was their last iodine? When did they have an iodine CT? Right? Not trying to call y'all out or anything. It's just be aware of that this stuff can sit around in their thyroid and reduce their uptake of iodine for a Nuke Med treatment. And it's going to have an insignificant effect on people with hypothyroid. Hypo low effect, right? If they tell me they got hypothyroid, I know that's good. There will be some insignificant effects related to that. Let me grab the book and just double check on what some of those effects are. Do y'all remember from the text? Oh, thyroid. You can see there's a big long laundry list of things that... thyroid function. Hypo, does she even say? Hypothyroidism, particularly with autoimmune Hashimoto thyroiditis, small temporary reduction in thyroid function that does not require additional treatment. So what am I going to tell this patient? I'm a technologist. Am I going to say, no, we can't do this scan? What am I going to say? I'm going to do the scan, and then what are you going to do? No, that's a good guess.
Just tell them that they might have decreased thyroid function, but it's not decreased enough for them to actually need treatment.
That's good. But what is something that I could tell them to do that is going to help them out? There you go. Drink more water. That's kind of like the Jesus answer for Sunday school today. Water, hallelujah. All right. When given to patients with hyperparathyroidism, we got a problem. It can precipitate a thyroid storm. That is not like an X-Man superpower. This is severe, life-threatening, bad stuff, right? So if you're talking to a patient who's got hyperparathyroidism, we need to be very, very careful with the use of it. We need to, so it says, contrast media affects patients with hyperparathyroidism. So this would be a person like with Graves' disease, right? Or thyroid autonomy. And so it doesn't necessarily impact the thyroid, but it could trigger this thing. So let me see. So we need to talk to the radiologist about this one. Got a patient with hyperparathyroidism. What do you want me to do? Their BU and creatinines, this, and this. No prior surgery. Go to them, talk to them about it. Chances are they'll say don't use it. Pulmonary effects. So it can cause bronchospasms, hypertension, and edema. And typically these people are going to have had either asthma, hypertension, or heart failure in the past. So using an LOCM again, going to reduce the risk there. This is the slide that I like where she talks about giving everyone Valium. So Valium administered 30 minutes prior to CM administration can reduce the risk of seizure. And then also if a patient does have a seizure after contrast media injection, giving them Valium can also help in that instance as well. Okay. If you work in a CT department, you'll probably see people having seizures. Become accustomed to how best to respond to that. Okay? Largely what we need to do is just keep them safe, largely from don't fall off the table, right? And it passes pretty quickly. If it lasts longer than, start checking your watch. And if it lasts longer than 2 minutes, you may need to just go ahead and ship them out. Get them over to the emergency department because there may be something more serious going on that they need to treat. If it passes in less than a minute or so, I would just say continue the CT scan. Chances are you're doing a CT head on them, and they're going to need that information anyways, right? And they're going to be pretty tired afterwards. Delayed reactions. One caveat on that. I know there's a lot of crazy stuff out there in this world, right? And one of the things that hit Austin really big, especially it was a college town, was this stuff called bath salts, right? Aromatherapy stuff. What do you call it? It was a THC derivative or something, chemically altered to where it was off the FDA's chart. So you could do a drug screen on this individual and no THC is going to show up in their bloodstream. I'm talking about marijuana, right? These bath salts are serious business, right? And they can cause some crazy stuff. A lot of this stuff is being manufactured in China. And I have no doubt that the Chinese are just rolling around and laughing about folks who are addicted to this stuff. It is habit forming, right? And it can cause severely weird seizures, right? I don't know how to describe this, but like seizures where someone tears this room apart, right? I've seen one once. It was a freaky event. Like, you know that scene in the movies when Dracula comes up out of the coffin? Like that. So, don't do that stuff. Stay away from it. If you got friends, let them know it's bad stuff. And if you start to notice that in the hospitals, just be aware that this can be, there are substances out there that can cause people to have mind-altering experiences, and if they're having a seizure because of that, you will not be able to continue the CT scan in all likelihood. And protect yourself. Again, this goes back to supporting the patient. I'm going to support you in this headlock until I've got you back supported in the emergency room by the police. Delayed reactions. Anything from an hour to 1 week after contrast media injection, we're going to call that a delayed reaction. And the information is difficult to collect, but largely this is a reduced reaction like red spots, bumps, hives, right? Also like mumps, like salivary gland swelling. It's like, I just kind of feel cruddy and, okay. All right, that's enough about the iodine stuff. Let's talk about the GI stuff, right? We're not going to call it oral. We're going to call it GI because we might have the pleasure of doing an enema on someone. So it's going to help us to distinguish loops of the bowel from cysts, abscess, neoplasms. And we use oral contrast media quite a bit on studies of the abdomen and pelvis. And it says rectal administration for contrast media is useful in some indications. I'd say not, but what do I know? Largely, you can have someone drink like either, I think they use the Omnipaque with like apple juice or something like that. Omnipaque with Crystal Light, sometimes barium, but it's a diluted barium. It's like I think it's like 3 to 5% barium suspense. So it's not like the heavy-duty barium enema barium, right? If you use that, you're not going to be able to see crap. Like, I mean that literally. You will not see the crap. Like, all you will see is just a giant streak artifact across the entire image. How do I know that? I'm an idiot. But don't do that. So use a diluted form of it. If you're using gadolinium, you'll also need to dilute it, and that dilution, if you're giving it rectally, will need to be greater than the dilution if you're giving it orally, right? It will need to be diluted even more. Same reason. Generally, if a person, what would be one contraindication for giving them the LOCM in Crystal Light? When might I not want to do that? What's the big thing we've spent a lot of time talking about today?
Renal failure.
Renal failure and reactions, right? Mm-hmm. So what kind of reactions might Crystal Light trigger? Besides like sudden weight loss in tennis, right? What does Crystal Light's got yellow 5 in it, right? People could be allergic to yellow 5. So be aware that if you're giving someone Crystal Light, you may need to ask them, hey, are you allergic to Crystal Light? Because I'm going to give you this stuff in Crystal Light. I've had a significant number of people who have not been able to do it because I made this batch for no reason now, $200 down the drain. Barium, same thing. There's been a few reactions to barium. They largely think it's the flavoring in the barium that causes the reaction, not the barium itself. These are the kind of questions I'm constantly asking, like, how are you going to barf on me or, like, code on me, you know? Otherwise, we'll get along fine. So we typically talk about it as positive or negative. Most of the stuff that we use is negative. Water, by this definition, is considered negative because it's right around 0, right? Positive agents are going to have a higher Hounsfield unit. Negative agents are going to have a negative or neutral Hounsfield unit. And again, water is considered a neutral agent or like negative. Barium sulfate, 1 to 3% barium suspense. And a lot of times, like the protocol is something like, drink these 2 bottles of barium, drink one the first hour, drink the next one over the next hour, save the last little bit, drink it right before we sit down and do the scan. Gastrographing, you can go a little bit quicker. So volumen is going to be similar to water. It measures about 15 to 30 Hounsfield units. So visually, it's going to look about the same as water, but it will have a Hounsfield unit measure higher, because what level of Hounsfield unit difference do we need to be able to visually see? 10. Good. All right. The advantages of using this low Hounsfield unit: improve bowel distension compared to water. Water, if I give the water, it gets to the bowel, it's just going to absorb the water. All right, I'm not going to have good bowel distension. It goes quicker than the barium. People like that, right? Recognize, you tell your patients, hey, it's going to go quicker, but it's also going to come out quicker. I'll say that, you know. More effective visualization of both bowel wall and mucosa, and this is again versus water. Barium, we don't want to give it if they got perforation. No, 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 no. And this is one of the reasons people may move away from barium and just pour in the Visipake and the apple juice and saying drink it. Because if they have a perforation and that barium gets inside there, we're going to have some serious problems, like infections and stuff, and impactions like within the peritoneum. So leaking can cause peritonitis, so that's infection. And then there can also be like these little forms, these like little, I don't know what you call them, like little statues. Little barium statues in there, not good. So generally we're going to use the high osmolality iodinated agents. So that'd be like Hypake or I think Gastrografin. Patients hate the taste of Gastrografin. There's really not a lot you can do to mask the flavor. You can tell them, hey, it's a margarita. Pretend it's a margarita. Both the high osmolarity and low osmolarity positive agents can be diluted and administered orally. So good news. You can use, again, the Visipake. And the doses are similar to the barium. And a lot of times we're using Gastrografin just because it's cheaper. Just a couple more slides. So, in what circumstances would a low osmolality contrast solution be diluted and administered orally, replacing HOCM such as Hypake? Any guesses? Reminders from your...
D.
Let's see. No, it's actually not the answer, sorry.
B. B.
No, it's... yes, it's the trauma. Yeah. Trauma patient immobilized on the backboard. We might use the LOCM because of the risk to aspiration to the lungs. Okay? You really don't want to aspirate barium either. Okay? So, again, this is one of the reasons that's kind of leading people away from the concerns of cost and towards just, and also it's simpler, frankly, to just like, I can inject this stuff, I can also pour it in your apple juice. It's wonderful. It's a miracle. Water. Sometimes we use this stuff, but as I mentioned, it moves through quickly, but it does not distend the bowel. Air and CO2. This is going to be the negative contrast. It can be administered rectally. We use this in CT colonography. Have y'all ever seen a CT colonography thing? Looks like you're playing some kind of weird video game. It's like you're running through someone's bowels, and maybe a monster jumps out and polyp. Intrathecal contrast media usage. This is going to be the person that receives an injection generally under fluoro, and we go in and do their CT myelogram, right? So a lot of times we're not doing the actual injection, we're just scanning them afterwards. We're going to have them roll around, and then we're going to elevate their head before we do their CT scan. I'm going to have them roll around, because that in theory is going to help coat the entire spinal cord before I do the scan. And I'm going to elevate their head so they don't get a really massive headache. Has anyone ever had to have one of these things where they like inject contrast media into your spine? It looks incredibly painful to me. And they used to do this terrible thing. One of the big things that CT got rid of one of these days when we're looking at videos, I'll show you this, is, what was it even called? Oh, a ventriculogram. We don't do these anymore. Where in order to visualize the ventricles with X-ray, they would inject contrast media into your spine, sit you down in a chair that raises up in the air and flips you upside down. And then they start taking X-rays. And then they move you, and they take another X-ray. Probably top of everyone's list, perhaps next to the deficogram, right, where you sit on a chair and poop while they're x-raying you. I think of the two, I would take the deficogram. But the she's like, bad choice. That is probably top of everyone's list for number one exam I would not want to be done on me, right? CT scan obviated that. Now we just do a CT of your head, we're done. It was one of the first big selling points of the CT scan. Now we can diagnose stroke without doing this terrible procedure that's possibly even damaging to the patient. But we're still doing intrathecal contrast exams guided by fluoro, keep the patient's head elevated, and enroll the patient to mix the contrast media before scanning. They will then be discharged typically to like a radiography nurse to lay flat on their back for a little while before they're discharged. Any questions?